So Joanne asked me to present some of the observations and lessons learned that we gleaned through our effort with Kristen Page and others in reporting the more recent experience with newborn screen identified early infantile Krabbe disease. And one kind of potential future goal is to have a more uniform approach between centers that care for these patients. As I mentioned before, I'm a member of the evidence review group for the ACH-DNC. So just as an outline for the next few minutes, I probably don't need to convince you that nerve conduction studies are really important in Krabbe disease. They can show one of the earliest identifiable abnormalities in the course of disease. Nerve conduction studies are a marker for disease progression after treatment, but they can be technically challenging and highly variable between institutions. So I'll give a little background on what nerve conduction studies are for those of you who don't have to deal with them frequently, some of the challenges in the nerve conduction studies, and then a very brief proposal for a unified approach. So nerve conduction studies measure the strength and speed of signals through nerves. And so you can really just think of nerves as bundles of wires. So a nerve would be, a peripheral nerve is a group of axons bundled together. And when we measure them, we measure strength, which is related to the size of the wire, or how many healthy neurons are conducting the signal along the nerve fiber. And in a nerve conduction study report, this is reflected in the amplitude of the signal. The speed of the signal relates to the quality of the insulation on the wire, or the myelin. And this is reported out as latency or velocity. And Krabbe disease attacks, makes the myelin sick. And once the myelin is sick enough, the axons themselves can become sick too. Nerve conduction studies evaluate both motor and sensory nerves. The sensory nerve action potential, or SNAP, is reported out, and it's really a measure of the amplitude of large myelinated nerve bundles and the axons therein. And even though these are large nerves, they produce a tiny signal that's measured in microvolts. And this becomes important when we think about some of the variability between studies. For those of us who've seen these reports, or those of you who do the studies, I myself am not a neurophysiologist, so I don't get to actually do the studies myself. But when the studies are being done, nerves can be stimulated by either orthodromic or antidromic stimulation. So orthodromic means that the signal is being sent along the nerve in the right direction. So for example, the median nerve, if you're doing sensory studies, you would stimulate down here on the hand or fingers and measure somewhere more proximally. That's great, but when you put the recording electrode on the skin up in here along the arm, there's a lot more tissue you have to record through than if you had the recording electrode down on the hand. So for tiny signals, or either because they're tiny signals, because they're tiny nerves, or they're sick nerves, some electrophysiologists will opt to do antidromic stimulation, which means they send the signal along the nerve in the wrong direction, but it still propagates. So they can stimulate up in here and measure down in here. And that is called antidromic stimulation. And when you measure down the wrist or the hand, you're closer to the nerve because there's less tissue to measure through. So one variability between institutions and different EMG labs is whether or not they utilize antidromic stimulation. Motor nerves are measured using the compound muscle action potential, which is basically the summation of depolarization of multiple muscle fibers that depolarize after a motor nerve is stimulated. So in this picture, we have our motor nerve and the muscle belly. And so you have the recording electrode over the muscle belly, give a little stimulation over the skin here. The signal goes down and makes the muscle twitch. It doesn't necessarily make it jerk a lot, but it makes the muscle fibers depolarize enough that you can measure it as a CMAP. Because we're measuring over the muscle itself rather than a nerve, the signal is much bigger, and these are measured in millivolts instead of microvolts. But it's a more complex thing than just sending a signal along the nerve, because you have to have a healthy motor neuron, healthy motor nerve, neuromuscular junction, and muscle. So when the neurophysiologist is stimulating the motor nerve, they measure the CMAP as the deflection or the signal here. And then a little while later, the F wave can come along. So some of you, if you read the nerve conduction study reports carefully, you might have seen a comment about F waves. So I just wanted to explain what those were. So F waves require, if you stimulate the motor nerve, and if you stimulate it enough, it'll send a signal up and down the nerve. So if you have a supramaximal stimulation, it sends the signal up to the spinal cord through the motor neuron and then back down the motor nerve. And so as the signal comes back down, that's the F wave. So it's delayed because it has to go up to the spinal cord and back. Okay, so F waves, so I mentioned, is the conduction between the motor nerve, spinal cord, motor neuron, and back down the nerve. These are very sensitive in Krabbe disease-associated neuropathy and many peripheral neuropathies. They can be an early marker of disease, and they don't normalize with transplant, at least what's been reported in the literature so far. Unfortunately, though, the presence of F waves is unreliable if the child is sedated. So sedation is another variable that comes into interpreting these reports. In Krabbe, nerve conduction studies can be abnormal on the first day of life. So these babies can be born with a neuropathy. All children with EIKD, though, have abnormal nerves by 6 months of age. Based on the published literature, it's a little unclear if motor or sensory nerves are affected first, but when just thinking about the pathophysiology, it's most likely that sensory neurons are affected first because of the myelin. But with the data available, it's hard to make that statement firmly with data to back it up. Upper extremities might be more sensitive in picking up disease or disease progression than lower extremities, in part because the upper extremities are a little easier to record from. The severity of demyelination correlates with clinical severity. So this is really an important measure if we can get to it. So after transplant, many parameters in the nerves improve and some even normalize, at least in some patients. But then again, some patients that show initial improvement then have subsequent worsening. According to what's been published, particularly out of Duke with Siddiqui and others in 2006, the sural sensory latency was most likely to improve post-transplant, and the F waves never normalized. So I've mentioned challenges. So what are some of the challenges? Well, body habitus, which varies with age, varies with steroid exposure after transplant. And basically the idea is the more soft tissue you have, the more insulated those signals are going to be and the lower the signal that's recorded. And so it's kind of like the baby testing the temperature of the water versus the child all dressed up for winter. The patient size really affects electrode placement. And so, for example, in this adult here who's getting checked for carpal tunnel syndrome, stimulate and record, the stimulation and recording electrodes are a good distance apart, so they're not interfering with each other. But if you make the distance between the stimulating and recording electrodes a third that size in a newborn, or even smaller, then it can create some challenges as to what nerves you can record and where along the nerves you can record. And then the need for sedation, as I mentioned before. And additionally, there's lack of normal values. We don't have normal published values for all nerves at all ages. And standard procedures vary by institution as far as, which neuron or which nerve is routinely stimulated at different ages. So this is a little snippet from Kristen's paper earlier this year. So we tried to take nerve conduction study data from institutions that transplanted the first 6 Krabbe patients identified by newborn screening in the last few years. On the left is amplitude, so that's axon health, and on the right is velocity, so that's speed of transition or transmission, or the myelin health. And on the top is arm, and on the bottom is leg. So first, you can see that there aren't the same number of patients represented in every figure. Part of that is because not all labs measured an arm and a leg in all patients. And part of that is because some of the leg values just were not measurable. Now, whether that was due to technique, patient age, or the degree of neuropathy, we don't know. All we have is the data that was reported clinically. One thing we can say is that the arms were easier to record from than the legs, at least to get a measurable recording. And generally speaking, the parameters got worse over time. If we look at sensory nerves, they were even harder to get a recordable signal from, whether that's because they're just more difficult to record from because they have such a low signal, or whether they are actually affected by the disease more severely than motor neurons. We can't say. But the legs, again, are more severely affected, and there was worsening over time in the sensory parameters. So there are other ways to get at the peripheral nervous system. A good exam is one of them. We can check deep tendon reflexes, do a detailed motor exam, and use functional observations. You know, which hand does the child reach with? Do they have to use two hands to hold their cup? Things like that. And then for patients that are developmentally able, we could do detailed sensory testing with tuning forks and all those fun tools we get to carry as neurologists. And then there is some data about nerve imaging. And there was a paper by this group led by Kupper in 2020 that looked at peripheral nerve enlargement using ultrasound. There's other papers about nerve root enlargement on MRI, or optic nerve enlargement and optic chiasm enlargement. So we don't really know exactly how nerve size corresponds to neurophysiological parameters or how nerve size corresponds to functional limitations. But I think that that's an opportunity for more study. So finally, this is based on kind of just discussions that I've had with Dr. Jen McKenney, who is the neurophysiologist at Nationwide in Columbus, who has done these studies on our patients. And I wanted to point out some recommendations that we came up with. First, it would seem obvious to document the patient's age, which side the study was done on. It's very standard for labs to report the skin temperature because temperature does affect the efficiency of conduction, and then whether or not the patient was sedated. One kind of pearl for those of you who order these studies, it's good to tell upfront in the order which extremities and which nerves you want tested, because you don't know if it's going to be the same neurophysiologist. And sometimes the studies are affected by where the IV is placed. I had a patient I was monitoring a nerve conduction block in, and we wanted to keep examining the same extremity over time, but the IV got put in that extremity, so that we had to switch to the other side. So, things like that can get in the way of kind of standard reporting and standard data collection that we may not even think of. So, the literature that's been reported does recommend at least one nerve in the arm and the leg for both motor and sensory studies. So in the arm, we use the median nerve, we use antidromic stimulation for sensory studies, and in the leg, the peroneal nerve and the medial plantar mixed nerve. The reason I think that Joanne wanted, thought this would be an interesting topic for us to present is that nerve conduction could be a powerful way to select patients and predict outcomes, but it really requires a longitudinal and standardized data collection in many patients over time. And for anyone that is interested in kind of talking more about standardizing our approach, I would be very happy to receive emails or comments later on. So thank you.